meantime, a couple of people are still joining and thinking about participating more actively. Was anybody at VMR yesterday?
We got some nods from the group.
Cool. Yeah, it was cool, right? Yasmin, it was a POCUS VMR. It was the first one that I'd seen. I don't know if there had been others, but Ravi Singh was kind of leading the charge, and it was an interesting patient. There was a lot to talk about, but the main sort of finding that most influenced, I think, kind of decision making was when they ultrasounded the bladder and found it to be very distended with fluid. And it's actually, I was saying the other day that of all of the various applications of point of care ultrasound, to me personally, that's actually the highest yield. I just, I have missed urinary retention so many times, and promised myself never to miss urinary retention again so many times, that having a tool that helps you just very quickly, rule it in or out, is very helpful. And it's actually, it's the combination of like both high yield and ease of actually doing it. It's extremely quick. It doesn't take nearly as much skill as getting windows, of the heart or interpreting the various artifacts in the lungs and stuff. So a big plug to yesterday's VMR and to the main take-home point. At least that was for me. Okay, so let's see who. Amr, thank you for volunteering to discuss with us. I'd really encourage one other person to jump in, because this will be actually somewhat maybe less structured, less formal, and it's a cool case that I hope to tickle you guys with. So any other interest? Steph, let me give the reins over to you for just a second, and pull up some stuff from the case.
Sounds good. So I was that was actually the first POCUS VMR. That's really cool. I think we'll learn a lot going forward with them. Amr, do you want to just say hi to the group?
Yeah, hello everyone. Sorry, I just noticed Promise Lee volunteered before me, so I would like to give you the opportunity if you'd like, or we can both discuss if that's because you're asking for another one. I'm happy either way.
Yes, please stay and join us, Amr. And then Promise, I know you're going to be scribing, right? Do you have the bandwidth to comment as you go, or I would find it tough, but you're a pro at this, I know.
Sure, I mean, I will definitely try.
Awesome. Well, I'm excited to think out loud with you guys. And we'll kind of see what we can learn from Zavin's case. Yes, Hans, please. Thank you in advance. You guys are always great adding comments, and we'll make sure to pull those in from the chat also. Yay, Nikita. Awesome. You ready for us, Zavin?
Sure, let's do it. So this is a 70-something-year-old person, man, and he's being admitted to the hospital to receive a pacemaker. So he's generally been pretty healthy, but in March of this year, a couple of months ago, he had a STEMI. Interestingly, he was almost asymptomatic. He just felt like vaguely unwell and went to like a primary care doctor, and thankfully they did an ECG, and he was having a massive ST elevation MI. So he was taken to the cath lab, and this was at a different hospital from ours. And he underwent stenting of his LAD as well as RCA. There was a like 100% thrombotic occlusion of the LAD, but had disease in other coronaries as well. And thankfully things turned out well, and he was discharged. But then he scheduled follow-up with the cardiologist in our hospital system, where he, usually prefers to get care. And in the subsequent visits, he was noted to have some arrhythmias. And so he underwent a Holter monitor, which is a prolonged kind of cardiac rhythm monitoring, and was called back by the cardiology clinic saying, hey, you're having a very slow heart rates, intermittently going into complete heart block, and you need a pacemaker. So, they told him to come into the hospital, and they called us to admit him so that, they could place the pacemaker the following day, and we could monitor him and go from there. So, give you a couple of other things just from the chart, from the medical history, things we knew about him kind of after getting that call. He does have a history of atrial fibrillation. Benign prostatic hyperplasia, hypertension. And let me give you the rest of the history as well. So he's on apixaban, lisinopril, tamsulosin, atorvastatin, and aspirin. Clopidogrel, not aspirin. Family history, nothing relevant. He's lives with his wife, is very active, independent. He's a retired pilot, and doesn't smoke anymore or drink or use any recreational drugs. Monogamous. No allergies. So with that, I'll just ask you guys to sort of share, like, okay, you're admitting this patient. I mean, what else do you want to know? And then what are you already kind of thinking about, either, making sure that whatever other treatments are needed, that we do, any considerations around a procedure, any other kind of learning or teaching points from this case. Take it away. Really, it doesn't have to stick to any component of what I've given you at all.
Let me just, a couple good points came up in the chat as you were taking us through the story. When you were describing how this gentleman presented with really minimal symptoms with a occlusion MI, Amr, you made an important comment up front, which is you wondered about if he had diabetes or not. Do you want to just fill in the gaps for the group? Why did that pop into your mind as maybe a risk factor for this gentleman and how he presented?
So I know that diabetics can often have silent MIs that can be massive, which might have been his case. I see that he doesn't have diabetes in his past medical history, but I would still wonder about how much care he has, whether he, his last visit might have been 10, 20 years ago, or maybe he's just not been tested. Diabetes is by no means the only disease that can cause silent MIs to take place. There could be other neuropathies, other vitamin deficiencies, some hereditary disorders. I'm not an expert. I can't name many of them, but I know that there are many possibilities for that. And sometimes it could be just maybe perhaps deterioration of the nerves with age, or just a very strategically located MI, though a massive one would not be the case. Yeah.
Awesome. Really great thoughts just about how subtle his presentation is. Kudos to his primary care doctor, right? For getting the ECG, seeing how bad it looked and immediately addressing him with hospital referral. That was really great. And there's been just some other great thoughts in the chat too about how this gentleman developed this bradyarrhythmia for which being referred to the pacer. I don't know if anyone wants to, some of you guys that popped in the chat, if you wanted, unmute at all and sort of explain your thinking, but some nice work to try and tie the recent ischemic event into this new bradyarrhythmia. I think Mukund in particular was really thinking about that right coronary artery lesion and what effect that could have on the sinus node in particular. And I actually forget, can you guys remind me how much of the AV node is RCA perfusion? Zavin, can you remind us? I actually forget if it's multi-input or not.
So usually both the SA node and the AV node are perfused by a branch of the RCA, two different branches of the RCA. I don't know how common anatomic variants are that that lead to left-sided perfusion, but usually it's associated more with RCA disease and infarctions. Now, in this case, the patient had RCA disease as well, although the acute culprit was thought to be the mid-LAD. And then the other possibility, somebody, I think in the chat mentioned is, if this patient's main conduction problem now is complete heart block, right? If you have a baseline right bundle branch block, and then you have a, left-sided event that then impairs your left bundle or one of the fascicles, potentially one that, one of the two that wasn't broken and the other one already was, right? That can be the proximate precipitating event for complete heart block as well.
Great. I think the other comments I'll make, if I were with you guys admitting this patient, there's probably two things I'd want to make sure we understood. First of all, we know already his cardiologist is referring him for a pacemaker. I'd want to make sure we as a group knew what are the general categories of indication for a pacemaker. Pacemakers are used for bradyarrhythmias to provide electric pacing to the heart when the heart isn't going to do it itself. And my very simplified way of thinking of the indications are really two big categories. One is any symptomatic bradycardia or AV block at all. Having symptoms with a slow heart rate is a reason to provide a backup device in the heart for the heart rate to go faster. Or an asymptomatic but kind of scary and concerning higher degree heart block. So specifically asymptomatic kind of third degree heart block with specific parameters. If there's long pauses, if the ventricular escape rate is particularly slow, even if the patient doesn't feel it, these are all reasons why someone would get a pacemaker. And so, this gentleman seems to be falling into that second category, a high degree yet asymptomatic heart block. But the other big category in general is anyone who's got bradycardia and is symptomatic from it. I think the second learning point I'd bring to this case is he's coming in. We know he's got complete heart block, AKA third degree heart block. He's getting a pacemaker for that. What do we do if he goes into heart block on our team before the pacemaker goes in? hopefully that doesn't happen. But what do you guys think? I don't know if anyone wants to comment in the chat or out loud, but let's say we see it on telemetry before he actually goes to the EP lab. Great. So I'm seeing a mix of responses here for both pacing him with electricity and medications, as well as the consideration of atropine, which will kind of reduce the parasympathetic input to the heart. The important thing to know about complete heart block is it's heart block that's past the AV node. It's sort of more distal in the conduction system. And actually, atropine usually isn't ineffective. Unlike in symptomatic sinus bradycardia or an early second-degree heart block, turning off that parasympathetic activity, the heart should make the heart rate go faster. It actually doesn't work when the actual block is distal to the AV node, which is the case here. So I think important for our team to know off the bat, atropine isn't going to work for this guy, and we should, in fact, at that point, get prepared to transcutaneously pace or give medication that would make the heart beat faster, such as dopamine. Hopefully it doesn't happen before he gets to the EP procedure. We'll see with Zavin, but I think an important thought exercise to go through anytime you're taking care of someone who's had complete heart block. What do you got for us, Zavin?
Awesome discussion. I should have mentioned this. I'm sorry I didn't, but as part of the history of like, whoa, you were called and told, you have complete heart block. We asked him how he'd been feeling, the last few days while wearing the Holter, and he said totally fine. He hadn't been short of breath. He hadn't been dizzy. He hadn't tried to like exercise or anything either, but he hadn't had any of the symptoms that you would expect potentially for somebody who, might be in complete heart block. And I think that sort of ties into the great question you posed, Seth, which is that, some people in complete heart block will be in shock or very symptomatic, depending on the, ventricular escape rate, I guess. But some people can be totally asymptomatic too, and it can still be perfusing rhythm. It doesn't mean it's not, an urgency or an emergency to try to, supply a safety net, because at any moment, complete heart block could just degenerate into asystole. But I think if this person had gone into complete heart block while on our service, given that he had been asymptomatic before, it might have been okay to, to just monitor him very carefully and be ready to intervene, but not necessarily intervene immediately. So, okay, so let me tell you kind of how he looked. Actually, let me pose one more question to y'all. He's on apixaban and clopidogrel, right? So he's about to have an invasive procedure where you cut his chest and do a little surgery essentially to put a big chunk of metal, and then like cut into the vein and push the wire through the vein into the heart and all that stuff. Do we need to hold these anticoagulations? Haven't the residents on the call reflexively learned that if there's a procedure tomorrow, you're, NPO after midnight, hold anticoagulation, et cetera, et cetera? Does anybody know?
Anne-Marie kind of made the point about sort of the evidence that there is for continuation of therapeutic anticoagulation with these types of procedures, particularly when it comes to periprocedural hematomas. I know there's randomized control trial data, certainly from warfarin. Is this the warfarin study? And I assume, like most things with DOACs, we're sort of extrapolating with DOACs also, and that keeping him on the apixaban would be fine and maybe even reduce bleeding risk, as Anne-Marie mentioned.
Absolutely. And this is one of my favorite cardiology trial names. It's called bruise control. Yeah, and it showed that you don't need to interrupt anticoagulation or antiplatelets to put in a pacemaker. Okay, sorry to steal the screen share. Let me tell you how this gentleman appeared. So he looked well. His vitals, his temp was 98. The heart rate was in the chart, it kept being recorded as like in the 40s, but when we examined him, it was 70s, 80s, kind of irregular, but higher than that. His blood pressure, respiratory stuff were normal. His cardiovascular exam, JVP was flat, less than 5 centimeters. His heart was irregular. It was like regularly irregular. It was regular for several beats, and then there was an early beat, and occasionally it would be like every other beat. It was like lub dub lub dub, lub dub lub dub, lub dub lub dub. And interestingly, he also had a murmur at the base. It sounded like a flow murmur or an aortic murmur, but you could only hear the murmur with like the regular beats. So it was like lapush dub lub dub, lapush dub lub dub, lapush dub lub dub. The beats that came early did not have a murmur. Lungs were clear, no swelling, belly was fine. So
I just want to hear you do the lub ship that lub lub again. It just sounded cool.
lapush dub lub dub, lapush dub lub dub, lapush dub lub dub. So an intermittent systolic murmur at the base. Yeah, and then regularly irregular ectopic beats. Okay, so anybody interpret that exam, the vital signs? Anything to learn there?
I guess just to clarify for the group, so I think we need to address the 2 different heart rate numbers first. When the nurses or the nurses' aides are recording the heart rate, can you tell the group, Zavan, like how do they do that? Like where do they get that number from? Versus how did you guys get your number?
Yeah, so I think most techs, what they do is there are these little machines in our hospital that have like a blood pressure, cuff. They have a pulse oximeter and they have the monitor that displays the stuff, and it, automatically gets teleported into the computer system when those machines are used. So what they do is they put on a pulse oximeter on a patient's finger, and they attach the blood pressure cuff and press the blood pressure button to start checking the blood pressure. And in the meantime, the machine through the pulse oximeter shows the oxygen saturation as well as the heart rate from the pulses in the pulse oximeter reading. And then the respiratory rate, hopefully gets measured, but I don't know how.
Always ends up being 18 though.
Yeah, somehow it's always 18. And then, they check the temperature. So I think that's how vitals are done. And then, when I say on our exam, the heart rate, we didn't take all the vitals, but when examining him, auscultating, feeling his pulse, we concluded that his true heart rate was higher.
So let me go back. Yasmin had a good thought already about could premature beats sort of play into any of this, and want to see if Yasmin or anyone else in the group, can you connect and explain how that maybe could relate to both the heart rate discrepancy findings as well as perhaps the physical exam findings, with the murmur only being present on the regular beats and not the early beats?
I think I can comment on that. Perhaps
Great.
I'm wrong. So what I'm thinking is, so for a regularly irregular heartbeat, that's the things I can think of are atrial or ventricular extrasystoles. And if it was atrial, it would have to be going to the ventricles and causing a systole. And the fact that it's not causing a murmur, so assuming the murmur is from a valvular stenosis, like an aortic or pulmonary valvular stenosis, or regurg in the tricuspid or mitral, the extrasystole might be non-perfusing, so it could be not sufficiently opening whichever valve is involved, which in this case, if it's at the base, it should be that it's the mitral. So it might be just because of the location at which it's starting. It might be starting, for example, from the top going to the bottom, so it's not effective at perfusing the at sending out sufficient pulse of blood, and that explains why it's also the heart rate is also not being registered, so, at the fingers rather than when it was auscultated and was revealed to be higher. So that could be the case, but I'm not exactly sure which valve would be the issue. I'm also curious to see if it's if the murmur was present prior to his MI, because it could be a complication, a rupture of a septal muscle causing the mitral rigors, maybe. Yeah.
Awesome, Amr. Yeah, great thoughts. It comes down to, with these premature ventricular beats, right? There's not enough flow for the pulse ops to pick up the extra beats, or enough flow for the turbid blood flow through the valve to be heard with every beat as the murmur. Zavan, do you have other kind of comments or teaching points on that? It's kind of one of my favorite things, is to see someone who's in ventricular bigeminy, right? They have a regular narrow QRS complex and a PVC, and their heart rate on the pulse ox is half of what we actually hear it as when we auscultate. Other comments, Zavan?
That's exactly what was going on. And Amr, you described the phenomenon beautifully. And, when you have ventricular extrasystolic beats, ventricular ectopic beats, it's both that when it's a PVC, it's not as good of a contraction, right? Like the normal one. But also, even if it's a PAC, just by coming earlier, there's less diastole, less opportunity for the ventricle to fill, and thus less blood for it to eject. And that's why a lot of those early beats, are quote unquote non-perfusing, meaning the stroke volume generated isn't enough to feel the pulse, isn't enough for the pulse oximeter to detect a little wavelet, and isn't enough to create enough flow to make a noise and cause the murmur. So let me show y'all the ECG at the same time. Actually, let me show it to you in a second, because I need to transfer it from the other computer. But in the meantime, let me tell you what happened next. All right. So he got the pacemaker, went fine, and uncomplicated. The next day, he's ready to be discharged, essentially. And but we go in there to say goodbye. But when we're talking about him, I guess before that, we had heard the nurse had called and said that he had an episode of hematuria. So like he called the nurse and said, hey, I just peed blood, and said, by the way, this is the second time that this happened. It also happened like 6 weeks ago. So what do y'all think? Approach to hematuria. What do we do for this guy now?
What do you guys think? So Rafa's putting out there, is the urine dark in color, not because of blood? So even stepping away from a hematuria schema, if we just think of dark colored urine schema, thinking about all the other pigments in there that can do it, like myoglobin. That's a great thought, Rafa. Hans is making the point, we know this gentleman is on anticoagulation and an antiplatelet. We've kept those on. Those certainly put him at risk to bleed a little easier, whatever kind of insults may be there. And yeah, Amr, great thoughts about kind of thinking anatomically in the GU tract of if it is in fact blood, which we could check with the urinalysis, where is it coming from, starting with the kidneys and coming all the way down, including to the sort of the outer urethra area. It's a great just kind of anatomic approach for it. It's interesting that it's just sort of sudden, right? He had an episode 6 weeks ago, he was fine, and then it happened again. Anyone have thoughts on kind of the transient nature of it? Stone movement is a good thought. Easy thing to make sure for someone in the hospital is that he wasn't catheterized for any reason. I don't think he would have been in the EP lab, was he, Zavin, for a brief procedure like that? But certainly any iatrogenic trauma, if someone even was intermittently catheterized during the hospital stay. But it sounds like, Zavin, I thought as we would get a little more history, see if we knew anything about that episode 6 weeks before, check a UA, see if there was both heme pigment and RBCs there. And if there was, for this gross hematuria, really start thinking about kind of the anatomic lesions and places this could happen. Rafa says, give us the UA.
Give us the UA. Yes, I will. And so that was actually, the plan that was presented by the student was that, he had this once before, and in fact, he'd already been referred to urology, and they were planning to do a CT urogram and a cystoscopy, at the follow-up that was like scheduled 2 weeks ago. And we were like, okay, I mean, that sounds good. I think I agree most of the time. Someone mentioned, Hans, you were saying if it's a bleeding tumor, right, in a kidney or the bladder or whatever, a lot of times it's more persistent. But keep in mind, we're talking about macrohematuria here, right? And whether or not you're actually bleeding enough to see it, things can kind of go like this a little bit, right? Depending on the anticoagulation you're on or other factors or whatever. So I think the intermittency of it didn't necessarily, exclude cancer. So it sounded very reasonable to actually pursue like a hematuria workup, essentially. But actually seeing the UA made us kind of think a little differently about it potentially. So let me show y'all the ECG real quick, just so that we can forget about the heart and move on to the urine completely. But this was his EKG. And I guess just in the interest of time, let me just point out that, it's a perfect correlate of our examination, right? Here, so lead 2 is, down here, the rhythm strip where you have lead 2 for the full 10 seconds is where I'm going to be looking and kind of talking about. You immediately see these, wide complex beats that are not preceded by any P waves coming early after narrow complex beats. So this was the lub-dub, 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 right? And with the murmur occurring here after the narrow complex beat that had a longer time to fill and thus a bigger stroke volume, and then the early beat was the one that was not perfusing, right? This is also the difference between the perfused pulse rate of 40 or so, the interval between the narrow beats here, and the twice as frequent actual heart rate, right, that you're seeing. And the last thing I want to point out is that adding to the weirdness of this guy's rhythm, this isn't even sinus rhythm with PVCs. Check out this P wave in lead 2. It's upside down most of the time. So this is an ectopic atrial rate with bigeminous PVCs, except here it's an actual sinus beat. And then the other PVC that, or the other, EKG that the guy had, he did flip into AFib at some point. Here it is. And the other thing that sort of teaching point here that was important is you quickly see here that it's an irregular ventricular rhythm, right? Obviously this interval is longer than this one, But for a second here, right here, it looks like it's actually a regular ventricular response, right? And one of the other key points that our resident made was that if you ever see an atrial rhythm that is AFib or aflutter, or rather, like more importantly, if it's AFib, but with a regular and slow ventricular response, that is complete heart block. AFib should be irregular, right? So if the ventricles are beating with a regular frequency while the atria are going like this, then the atria aren't actually getting to the ventricles at all. And that is, so regularized AFib is a red flag for a complete heart block and important to detect. Wasn't the case here, but good to learn from. Okay, promise, sorry again, I took over, but please share the screen again and I'm gonna tell you the UA. And I'll stick to the whites and reds, all right? So it was 391 white cells and 35 red cells. That is your aliquot.
What do you guys think? Anything surprising about the UA cell counts? Yeah, people are noticing, right? The white cell count is right 10 times as high as the red blood cell count. I was expecting the red blood cell count to be a lot higher. So now we're getting some great questions in the chat about any infectious inflammatory symptoms that he has. Some good thoughts already about where, if there is inflammation in the GU tract, where, including a prostate in an older man. And then Max is making a point about just the morphology of the reds. Are they just whole red blood cells? Are we worried at all that they look dysmorphic in any way? So did he have, other than seeing red urine, did he have other symptoms, Avin?
So that's the key question, right? And by the way, this whole time that we're looking at this UA, we're still outside of the room. And, when we immediately, I had a couple of thoughts. I was like, that's weird. You can't see 35 red cells. 35 red cells is not enough to discolor the urine and have it be visible. So that was a weird thing. But the other thing is what everybody kind of noticed is this is like 10 times as many inflammatory cells as their red blood cells. So is this really a bleeding problem, right? Or a bleeding structure problem? Or is this an inflammation problem that comes with a little bit of bleeding, which isn't, uncommon. So to me, immediately seeing this UA, the problem got reframed. This isn't hematuria. This is predominantly pyuria, with a small hemorrhagic component. And, we started talking about this a little bit. And then one of the kind of reflexive comments that got brought up was, oh, okay, but we don't, he's asymptomatic and we don't treat, asymptomatic kind of abnormal UAs or asymptomatic bacteriuria, right?
Unless pregnant, Rafa says.
Unless pregnant, good, okay, doesn't apply here, but otherwise, right. Or having a GU procedure, okay, good. But not having that yet either, not today. So, right.
Well, and I guess the question is, we don't know yet if there's bacteria in there or not. If there is no bacteria, then both infectious and non-infectious things can still cause pyuria that you might treat depending what it is. So did the UA say if there was bacteriuria?
I don't remember, but let's maybe not. Let's suspend that for a second though. Rafa really wants the culture, which is Steph, what you're asking for too, right? Is it just inflammation or inflammation with bacteria, right? And there's a lot of things that cause non-bacterial inflammation of the urinary tract, right? Sterile pyuria, and those are important to discover. Amr, let me like ask you this. If you can have a STEMI and be asymptomatic, can you have a UTI and be asymptomatic?
I mean, I've never thought about it that way, but now looking at it, it should make sense. It's I think these visceral nerves, I would assume that they are of the same caliber, and it makes sense that if one side is affected, that the other might be affected as well. But I've never honestly thought about it that way. Yeah.
You absolutely can, right? Like there's no, I think people are often, too absolute with that sort of dogma that is, is coming out of like our need to stop over-diagnosing UTIs, right? But I think it's good to sort of have some perspective. Here's the other observation that I've kind of made over the last few years since this kind of understanding that symptoms are an important component of diagnosing a UTI. Most people who, most patients that we say like, oh, this is asymptomatic, we actually haven't done due diligence to make sure that they truly are asymptomatic. So we go into this guy's room, and this is just some interval history. And what he describes is that he says, okay, both times that it happened, I started peeing, and initially it was clear. And then at the very, very end, when I was about to when the stream stopped, like several drops of blood came out. And that was the hematuria that was described. And in fact, he also said that by the time when he gave the urine sample to the nurse, the UA that we were looking at, it didn't happen again. It was completely clear urine, which sort of confirmed the whole 35 red cells don't discolor the urine. Yeah. So we talked some more, and initially, we asked some more questions, and it turned out that, we looked for symptoms, and, there were no irritative symptoms, it seemed. But then, we looked back in a chart, and he prompted us to kind of look more closely going back. And, he had a couple of months ago when this happened again, that hematuria, he had a UA at the time, and that UA showed 980 white cells and 13 red cells. This was June 2nd, all right, 2 months ago. And there was a concurrent urine culture at that time, which grew greater than 100,000 Klebsiella pneumoniae. And he told us that at the time, he got antibiotics for that. And he made an offhand comment. He said, and I think it helped. I got better after that. So imagine being in there, and based on what you've heard so far, y'all, he says, I got better. What are you wondering?
I think Carolyn put a good just point in the chat of sort of how to frame this symptom. She used the phrase like terminal hematuria, that it seems like he is experiencing, he has a symptom. So I think given that history with the positive urine culture and the way he's describing this episode, maybe we have data now to actually worry about a recurrent infection, with terminal hematuria kind of being the symptom.
I obviously haven't. That's absolutely right. And by the way, for whoever mentioned terminal hematuria, kind of thinking of the prostate, you know, I had a vague association with that. One of the other team members, I think one of the interns, like had a stronger association and immediately like thought of, you know, the prostate. But no, when, you know, I haven't represented our conversation fully, obviously, I couldn't possibly, but something when he said I got better, I was like, wait a second, what got better? Because you've been feeling perfectly fine, right? And the only actual symptom we know of that you've had are these 2 episodes of like, you know, having a little, like a couple of drops of blood at the end of the stream. And I was like, wait, what got better? And he goes, oh, you know, like the burning. And we're like, wait, what? When did you have burning? And he was like, well, I mean, this morning and like the last couple of days. And also like back then, I think I had some like discomfort when I would pee. And it was a great example again of that, like taking a history is really hard. Providing the history is really hard for the patient. And then so much gets lost in the communication. And, you know, there was another like viral tweet recently about like, you know, when attendings take, you know, whatever, like the patients, it's the term that was used was historical alternans. You know, it's this like joke about the, you know, the student asking the same questions and then coming back with the team and the team asking the same questions and there's like different answers and you're like, what? I asked you that, right? And I think so much of, you know, the communication is just hard and people misunderstand each other or patients don't remember things fully. So I think asking the same questions again or in different ways, using different words, you know, can just give you completely different understanding of the true experience that the patient has had. So we actually like took it a step further and like sort of pressed on his bladder a little bit. You know, the abdominal exam we had done, you can imagine initially wasn't a very good abdominal exam, right? I think appropriately so.
He's here for a pacemaker. He switched
He
it
was
up
here
on
for a
you.
pacemaker, like he's fine, right? So he had a little tenderness even over his bladder. So, you know, we checked the PSA and it was normal. So we didn't think he had acute prostatitis, nor was he quite kind of systemically inflamed enough. But he probably had chronic prostatitis, or maybe he does have some structural thing in his bladder that predisposes him to recurrent infections. But this did change our management overall. We did decide to sort of call this a UTI and treat it accordingly. We you know, used a prior cultures to choose our empiric antibiotics, but got a repeat culture to make sure the organism hadn't changed or become resistant. And then we kept his urology follow-up, but we communicated, you know, that sort of things might be a little bit different than the impression that we'd all had initially. And depending on follow-up UA and you know, culture results, it may be appropriate to sort of like defer some of the invasive workup and monitor for a little bit. Rafa, we did not do a rectal exam. I don't remember, but we had a lot of sort of UTI prostatitis patients that week. I don't remember if the residents went back and did one. We didn't do it together. Okay, that's all I have. Curious to hear y'all's reflections and additional teaching points from anybody, but Amr, Steph.
I'll just say it was, I liked kind of just going through, right, this wasn't sort of the presentation, but the clinical course a patient had on the team, and that's its own different, very important kind of clinical reasoning. So I really enjoyed the exercise. Amr, do you want to share any kind of reflections before I do?
I mean, I really appreciate these maybe newer forms of cases that we're doing here. I love, you know, thinking about what the underlying illness is and, you know, a rare vasculitis or lymphoma. But, you know, for our everyday patients and learning, these are probably even more valuable to, like, for every student among us, or those who have just finished and are studying for some exam. A UTI is just an easy question. You just think 1, 2 UTI and that's it. But to think about it in that way, and to see experienced clinicians saying that it might get missed so easily, and thinking about asking the patients again, repeating the exams, not taking any, even things such as a heart rate, to think about how was it taken, where did it come from. It's not so many valuable points. I'm very grateful to have been here today.
Yeah, my two reflections are very, very tied to yours. One is often when we do these case exercises, the data is just presented to us as is, and it's facts. But even something as quote unquote simple as collecting the vitals, right? It's important to understand how it's done, where error can come from, or I shouldn't even say error, but where discrepancy can come from, like the pulse ox, picking up a pulse versus your stethoscope, actually hearing valves close more frequently than that. And then it happens all the time that sort of why someone comes to the hospital is framed to us in one way. But by stepping back and actually listening to the patient, taking a story, you often find other issues that are really important. So I think I'm sure, Zavan, this was quite purposeful in your mind, but a great case to just emphasize the importance of history and actually finding out from the patient what's going on with them besides, oh, why did this doctor kind of want them referred to us? Awesome. Anything else you want to add, Zavan?
Y'all said it perfectly.
Leah, want to take us home with some of the teaching points?
Yes, so thank you everyone for adding your thoughts and the discussion. I think we had a very first starting off with more cardiology based, and then getting into maybe more generally how to consider the clinical exam and information we get from the patient. So we started off by talking about how silent MIs are more common in patients with diabetes and neuropathies, and also we have to think about that when we treat elderly patients. And then we talked about conduction problems as a consequence of ischemia. And this patient actually came in for a pacemaker placement. And the indications for that are usually bradyarrhythmias. And you can think of two buckets, kind of. You can have the symptomatic bradyarrhythmias and the ones where you have concerning higher degree blocks. And then we talked about treatments for complete heart block. And it depends on the situation and the setting the patient is in. But because atropine is ineffective, you consider monitoring or transcutaneous pacing, and also dopamine to raise the heart rate. And another interesting pearl we learned is that according to the bruise control trial, it's not necessary to stop anticoagulation or antiplatelets for pacemaker replacement. And then we talked a lot about premature ventricular beats. And the etiology of this could be ischemia, disturbances in electrolytes, also medication that can cause it. And something interesting to consider, because we always think of AFib as an irregular beat, but 3 cases where you can have AFib together with regular ventricular rhythms would be in a complete heart block, in pacemakers, and also with ectopic beats. And then an interesting point also was we had a discrepancy between the auscultation and the pulse. And this is due to the fact that often PVCs are ineffective contractions. So you don't actually feel the pulse when you measure it because the contraction is not a real one. And it can also happen with premature atrial contractions because there's less filling, so we'll have less output. So always keep that in mind. And then finally, we talked about how important it is to revisit the history when we think of asymptomatic patients. Is he really asymptomatic, or is it just that we didn't ask the right questions? And yeah, talk to the patient again is always a good idea. And finally, there's pearls shared by Rafa for locations of terminal hematuria, which could be bleeding from the prostate as well, bladder, or the urethra. Thank you guys for joining today.
Thanks, Leah. That was great. Have a great Wednesday, everyone. We look forward to seeing you next time. Take care.
Thank you for not ending the meeting. We're all, I think, reading the chat.